Assalamu alaikum and good morning. My presentation is third on the line right now, and it's on malignant bone tumors. Stuart Scott was an American sportscaster at the ESPN who died of appendixia. He brought in so the saying by Stuart Scott was, "You beat cancer by how you live, why you live, and in the manner in which you live." So he died in a young age with appendicitis. Was a very renowned sportscaster and anchor in ESPN. Quite a motivational saying by him. Osteosarcoma, a disease that even predates mankind. So in a research done in Canada in 1989, they found a deformed bone from a Centrosaurus, and in recent examinations under microscope and under advanced technologies such as high resolution tomography, it revealed that the lump in the bone was the size of an apple, and which was in fact an osteosarcoma. So although we cancers are quite common in our age or in the recent decades, but it even predates mankind. So it's about osteogenic sarcoma is the most common malignant bone tumor and is one of the deadliest bone tumors, and most common cause of death is usually pulmonary metastasis. It has got two peaks, one of them from the 10 years of age till 20 and one beyond 50 years. And its distribution is around the knee joint, hip joint, and the shoulder joint. Clinically, it usually presents as pain, limping, a mass or swelling around the joint, and at times it can present as pathological fractures and respiratory symptoms. Coming to the pathophysiology, the most common site involved is the femur, usually the distal end, which accounts for about 42%, the tibia, the proximal end, which accounts for about 19%, and humerus, usually the proximal, which accounts for about 10%. The skull, jaw, and pelvis, they are around 8%. The exact cause is unknown, but there are many risk factors, and one of them being rapid bone growth, and that is why it is more common in adolescent growth spurt. Then there is genetic predisposition, Paget's disease, Freiberg's dysplasia, achondromatoses, hereditary multiple exostosis, retinoblastoma, Rodman-Thompson disease, and radiation-induced tumors. Epidemiology, it is slightly more common in males. It comes to 1.22:1, and according to our data collected by the NCI and SEER, the National Cancer Center and Surveillance Epidemiology and results, they found out from 1973 to 2004 that the black population is usually 3.4 cases per million, and almost 5 per million were less than 25 years of age. And for whites, it was slightly lesser, around 3%, 3.0 cases per million per year, and 4.2 per million were less than 25 years of age. Again, with this monograph that Sear did from 1973 to 2004, they gave the overall relative 5-year survival rates. So they found out that the age of the cancer, if it's in less than 25 years age, there is 61% survival rate, slightly more in females, 65.8, and in males around 58.4. And the second group, if the age is beyond 25 and around 59, 60 years, it's around 58.7%. Again, the females have a better chance than the males. As the age goes on, say coming from 60 to 85 years, it comes to 24%, and there's a drastic drop with advancing age, coming to around 10% beyond 60 years of age. The lab workup that we usually do for osteogenic sarcoma is more for the management rather than for the diagnosis. But the lactic dehydrogenase, if it is raised, it gives you a bad prognosis. Alkaline phosphatase, if it is very high and raised, it also predicts the pulmonary metastasis. Then there is a battery of tests we do, like the CBC, the platelet count, LFTs, bilirubin, electrolytes, renal function, renal analysis. This is all for the subsequent management of the tumor. Okay, when we come across a plain radiograph, we always have two views of the X-ray or the affected limb, and the osteogenic sarcoma can be purely osteolytic and purely osteoblastic. It's around 45% cases are osteoblastic and around 30% are osteolytic, but we can have a mixture of both, the blastic area, lytic area. The next investigation we usually do is a bone scan, PC99 bone scan, and it gives us the evaluation of the presence of metastasis and multifocal disease. And once the bone scan is done, the abnormal area should be obtained. Abnormal area should usually be ascertained by CT scan or an MRI. Okay, then the CT scan of the primary lesion and the CT scan of the chest should always be obtained. As I've shown in the pictures, you can see the mets in the chest and how the CT scan appears in the distal femur. So this gives us the help in the critical staging of the tumor. MRI of the lesion, we can count it as the image modality is perhaps the single most important study for accurate surgical staging of the lesion with the use of anything a staging system. The MRI should be done for the entire compartment. It also tells us about the intramedullary disease as well as associated soft tissue masses and skip lesions. PET scan, although quite expensive in our country, but usually is very helpful, and it not only helps in diagnosis of the primary lesions and metastasis, but also for histological response to new adjuvant chemotherapy and prognosis. And usually it appears as a Christmas tree effect usually seen in the PET scan. The mets usually glow because of the when seen on the gallium camera. This I have taken from the Eniking, and I did it in the last talks also. So just a brief review. The stages 1A, 1B are usually low grade, 2A, 2B are high grade, intercompartmental, extracompartmental, 3A, B are any grade tumors with distal metastasis, and intercompartmental will be 3A. And if it has got distal metastasis and it's extracompartmental, it's usually 3B. Then the Weinstein staging of spinal tumors, although a little confusing, but it should be taken like a clock. So we start from the left-sided spinous process and the lamina. We take it as 1 o'clock, go around till the body, 6 o'clock. Then we come to the right side and again ending up in the right side of the spinous process. So this gives us the exact location of the tumor, and then going radially, how deep is the tumor? It is graded as A, B, C, D, E until we reach the spinal cord. So this gives us just the rough estimation of the depth and the spread of the spinal tumors. So the most important part in management is to stage the tumor, and staging is important whether the tumor has metastasized or not. So other tumor features that not technically using staging may be impact the prognosis. The following 4 are very important, as I told you before: the LDH and the alkaline phosphatase, the site of primary tumor, mostly related to ease of complete resection, the histological response to chemotherapy, and usually the cause of the disease. For example, Paget's disease has a particularly poor prognosis. And coming to the sites, the distal extremities have the best chance of survival. The distal femur coming more proximally as intermediate, and axial skeleton has the worst prognosis. Again, this TNM classification, I did it in my first talk, so I won't go in detail, and I'll let Dr. Ali Gilani and Dr. Naila to discuss this. Just to remember that how we start from the primary tumor to the lymph nodes, the distal metastasis, then the histopathological grading, and the stage grouping. Then classification of osteosarcoma, the primary conventional one is usually intramedullary osteogenic sarcoma, then the secondary osteosarcoma, then osteosarcoma specifically with certain syndromes, then surface osteogenic sarcomas, intracortical osteogenic sarcomas, and extraskeletal sarcomas. Our primary focus will be on conventional, which are osteoblastic, chondroblastic, fibroblastic, malignant, fibrous osteosarcoma, osteoblastic, giant cell rich, small cell telangiectatic, and in surface we'll focus on parosteal and periosteal osteogenic sarcomas. Conventional intramedullary osteogenic sarcomas, how they appear on X-rays, CT scans, the gross picture of the specimen, and a lot of anaplastic cells and full of osteoid. This is how a conventional osteosarcoma will appear. So, as I told you, is the most common primary malignant bone tumor characterized by production of osteoid or bone by tumor cells. Malignant cells also retain the potential to form either fibrous tissue or cartilage. So the constituents of the tumor matrix are highly variable and can include osteoid, calcification, fibrous tissue, cartilage tissue, or a combination. So the biopsy can be very tricky. Usually these patients, as I told you, present with swelling around the knee or shoulder and may also present as pathological fractures. The lesions commonly rise eccentrically in the medullary cavity with ill-defined cortical destruction and soft tissue involvement. And as I told you before, the pleomorphic nature of the histology may cause misleading biopsy results. Again, the typical histology of osteogenic sarcoma, all anaplastic cells, malignant cells with abundant osteoid tissue. This is how it appears on plain X-ray. Eccentric lesion with the soft tissue mass and the gross appearance of the tumor. This raised angle usually is the Codman's triangle. This is a young X-ray of a young 14-year-old boy showing a classical osteogenic sarcoma, areas of blastic and lytic with Codman's triangle. Then the tumor can also present as sunburst appearance, sun ray appearance. This is how it shows up in the X-rays. Then coming to the various other modalities, MRI can show you in T1 images. We see a lesion in the distal femur. In T2, we see the soft tissue area around the tumor, the lytic and blastic nature. Similarly, seen in the axial views. This is a purely blastic lesion, which is showing a distal lesion in the distal femur with extensive cloud-like mineralization. These are the coronal views, sagittal views, all showing soft tissue destruction, extracompartmental involvement of the limb. Then we come to secondary osteosarcomas. I told you, usually the commonest is the Paget's, not in our setting. We usually have fibrous dysplasia, post-radiation, and at times even the metallic implants and chronic osteomyelitis can lead to secondary osteosarcomas. Then coming to the other varieties, I told you this is the periosteal osteogenic sarcoma. It usually involves the periosteum and spares the medullary cavity. It's an intermediate grade surface tumor and it has got an intermediate prognosis. So this is how the bisected tumor looks like. Again, another view of the periosteal osteosarcoma. So it's a slow growing tumor with a better prognosis and usually involves the surface of the bone and involves almost all of the periosteum. So this is how it appears in the X-ray. Lytic lesion, which has got a large soft tissue shadow. So not involving the whole of the medullary cavity, but just the surface of the bone. Then this is how there's abundant prominent cartilaginous cells seen, bluish and these dotted red cells with very little osteoid. The other variety is the Periosteal Osteosarcoma, which comprises only for about 1% of the malignant tumors. It is again a slow growing tumor, and in comparison to periosteal, it is even away from the periosteum. You can see a really lucent area between the bone and the tumor, and it usually has undulating surface. So this is how it appears in the X-ray, the MR, and the gross appearance of the lesion. The whole of the bone is usually spared. The periosteum is spared, but there is a mass which is lying outside the periosteum. This is how it appears on the X-ray. You can see a bony tumor with undulating margins, but there is a radiolucent area which separated from the bone. So characteristically, these are slow-growing tumors. So there is abundant malignant cells with osteoid and giant cells, and there is usually 25% have medullary involvement and 15% have coexistent areas of dedifferentiation. Okay, but one of the highly malignant forms is the telangiectatic osteosarcoma. Usually very hemorrhagic, can appear as bag of blood, and it mimics aneurysmal bone cyst. Highly malignant, and metastasis is usually towards the lungs, pulmonary metastasis, and it has got a very bad prognosis. This is how it appears in the X-ray. Eccentric lytic lesion, so that's why it can mimic an aneurysmal bone cyst. So these are areas of blood, hemorrhagic areas with abundant anaplastic cells with some osteoid. After coming to the pathology and X-rays, we have certain societies, the National Comprehensive Cancer Society, the European Society for Medical Oncology, the European Reference Network for Pediatric Cancers, and the European Network for Rare Adult Solid Cancers. I'm sure my panel, Dr. Naila and Dr. Ali, are going to tell you some details about it. I'll just tell you the recommendations they have given for the stage-wise treatment of these tumors. They always recommend that the patient should be enrolled in a clinical trial, should be considered when available. And whenever possible, patients should be referred to a tertiary care center with expertise in sarcomas. So in the management of stage 1 or stage 1B low-grade tumors, the NCCN recommends wide local excision alone, and chemotherapy prior to excision is not typically recommended. For low-grade intramedullary or surface osteogenic sarcomas, like periosteal sarcomas, they usually recommend post-op chemotherapy after excision of the tumor. ESMO or Eurocan recommends surgery alone for low-grade tumors. So by NCCN, they do recommend post-op chemotherapy, but the Eurocan or ESMO they don't. And they also, their guidelines that conquer the combined proton, photon, or proton beam radiotherapy for local control is an option. For stage 2A till 4B, the higher grade tumors and metastatic diseases, again they recommend that the patient should be enrolled and it should be done by a multidisciplinary team, and the pre-op chemotherapy followed by post-op, which we call the neoadjuvant therapy, is recommended. If good margins can be achieved, limb-sparing surgery is preferred for patients with good histological response for chemotherapy, and amputation for tumors in unfavorable anatomical locations. Post-op chemotherapy should combine with pre-op regimen if there is a good histological response. And for patients with a poor response, we consider different regimen. Surgical re-resection with or without radiation therapy for positive margins should be considered for unresectable osteogenic sarcomas. And following pre-op chemotherapy, consider radiotherapy or chemotherapy. For metastatic diseases, for resectable metastasis disease, pre-op chemotherapy followed by a wide margin excision, and again then followed by chemotherapy, and metastasectomy is a treatment option. This guideline is from the NCCN. For unresectable metastatic diseases, chemotherapy with or without radiation therapy, and then we reassess the primary site for local control. The ESMO recommends that primary metastatic osteogenic sarcoma should be treated with a curative intent, following the principles of non-metastatic osteosarcomas. For relapsed or refractory osteosarcomas, the guidelines recommend second-line chemotherapy resection for both. Then again, we can go to re-resection or palliative radiotherapy. Chemotherapy regimens, which my panel is going to describe you more. The guidelines note that doxorubicin, cisplatin, high-dose methotrexate, and ifosfamide have a great anti-tumor activity in osteogenic sarcomas. Then these are various drugs. If the first line fails, then we have second line drugs like ifosfamide, sorafenib. So again, I'll request Dr. Naila to give you a detail about this. So what's the current standard of care? Once we have staged clinically and radiologically, the biopsy is done to confirm the diagnosis. We give them pre-op chemotherapy. Then we repeat the radiology, assess the chemo response, finalize the surgical plan. Then we do the surgical resection with wide margin, reconstruct using one of the many techniques. Well, I'll just briefly tell you, and post-op chemo based on pre-op response. So the main goal of surgery is to safely and completely remove the tumor. Historically, amputation was the gold standard. But over the past few years, because of advances in chemotherapy and sophisticated imaging techniques, we can go to limb salvage now. But for, again, pelvic tumors, you usually require a hemipelvectomy, and spinal tumors, which are difficult to resect. So we do vertebrectomy or combined with end block resection or mechanical stabilization. Post-op, these patients can be treated with extracorporeal radiotherapy or radiotherapy alone. As I told you, amputation involves removal of the limb with a safe margin. It should not be viewed as a failure of treatment, but rather as the first step towards patients' return to a more comfortable and productive life. So what are the indications? Usually grossly displaced pathological fractures. If the neurovascular bundle is involved, tumor that enlarges during pre-op chemo and is adjacent to neurovascular bundle, if the palliative measures in metastatic disease are not favorable, if the tumor has caused massive necrosis, fungation, infection, or vascular compromise. So these are the indications for amputations. So if we can remove the tumor with a normal cup of tissue surrounding it with it while preserving vascular and nerve supply, then the limb salvage is an option. The guidelines say that if there is, again, no neurovascular involvement, end block removal of all of the tumor along with the biopsy site, and resection of bone for 3 to 4 centimeters beyond the abnormal uptake as determined by CT, MR, or PET scan, then with an adequate motor reconstruction, then we can go for limb salvage surgery. This is an old technique known as rotationplasty. Usually it's between amputation and limb salvage, mostly done in osteogenic sarcoma in young adults. It's a procedure in which we do a below-knee amputation, but by preserving the neurovascular bundle, and by rotating the limb, we can use the ankle as a knee. As shown in these pictures, the tumor which was resected, rotationplasty was done, and then it has been used as a knee for prosthesis. These tumors are very radio-resistant, so radiotherapy has a very limited role. So if their indications are if the tumor is unresectable, if it's incompletely resected tumors with positive margins, patients will refuse surgery and for palliation of symptoms. Again, the radiotherapy can be intraoperative and has been used to deliver dose directly to or close or to the involved surgical margins. Then proton particle therapy has been used in an attempt to escalate radiation dose, and radionuclide therapy like rhenium, strontium, and samarium. They are usually palliative measures. Complications: radiotherapy obviously will weaken the bone, can cause scoliosis, decrease range of motion of the joints because of fibrosis, vascular changes resulting in greater sensitivity to infections, lymphedema, and radionecrosis. Just briefly about extracorporeal irradiation. It consists of an en bloc removal of the tumor-bearing bone segment, removal of the tumor from the bone, irradiation, and reimplantation. It was done way back in 1968, and around 50 to 300 grays of radiation are used. The advantage is that it provides an anatomically sized mass graph of biological reconstruction. So several cases series from India by D.N. Sharma and outside world showed excellent long-term local control in osteogenic sarcoma, Ewing sarcoma, and chondrosarcoma if 50 grays are used in a single fraction. This was all about osteogenic sarcoma. I'll try to wind up the chondrosarcoma. Again, it's a cartilage tumor comprising of about 9% of all primary bone malignancies. It can be primary from the age of 40 to 60 years and can be secondary between the age of 35 to 45 years. So divided into primary and secondary types. The primary can be central, intracortical, clear cell, mesenchymal, and dedifferentiated. Secondary can arise from multiple chondromatosis, chondroblastoma, and radiation-induced and fibrous dysplasia. This is how it clinically appears: a slow-growing palpable mass, which is usually continuous with the bone. It's hard in consistency and usually lobulated and causes mechanical restriction of the joint. The gross appearance of the tumor, we see areas of myxoid, hyaline cartilage, the bluish-grayish areas, zones of brown tan which are hemorrhagic and lacking the consistency of cartilage. They may also be so extended that little cartilage is in very highly malignant forms. This is showing a high-grade osteogenic sarcoma of the third digit. This is how clinically it appears. Histologically, you see an abundant cartilaginous matrix with chondrocytes embedded in lacunae and lobular or diffuse growth. Then they are, according to the mitotic and nuclear radiography, they are divided into grade 1, 2, and 3. Grade 1 have minimally increased cellularity, nodular growth, and occasionally binuclear nuclei. And grade 2 are moderate cellularity and diffuse growth. The grade 3 have high cellularity, marked atypical cells, pleomorphic appearances, and easily identifiable mitotic figures. So they are again divided into grade 1, 2, 3, as I told you in the slide before. On plain film, so how are they going to look on plain film? They usually appear as lytic lesions in 50% of cases. The most important part is they have intralesional calcifications, rings and arcs or popcorn calcification. You can see endosteal scalloping and even moth-eaten and permeative appearances, and periosteal reaction distinguishing it from enchondroma and chondrosarcoma. So this is how an enchondroma will appear, and this is how chondrosarcoma will appear. So proximal tibia showing a case of subtle calcification, but when the MRI is done, you see how extensive is the involvement with scalloping of the endosteum. Again, X-rays and MRIs, you see this all calcified area, usually seen in the pelvis, in the ilium, and how they appear as a soft tissue large mass. This is a secondary chondrosarcoma arising from an osteochondroma. Conventional chondrosarcoma, this is a plain radiograph which shows this is in the fibula. This is how it appears on the MRI. Characteristic hyperintense lobulated lesion with internal septations. And chondrosarcoma on the chest wall, see it in the rib. Approach to the guidelines for treatment of chondrosarcoma have been again developed by the NCCN and jointly by the European, the ESMO, and the other bodies that I mentioned before. Radiotherapy and chemotherapy play a very limited role in primary treatment. An exception in their use as adjuvant chemotherapy or palliative treatment is surgically inaccessible areas. Diffuse metastasis is usually an indication for systemic radiotherapy or chemotherapy. But the gold standard is for chondrosarcoma is surgical therapy. Complete wide surgical excision of the chondrosarcoma is the preferred method when it's feasible. Success usually depends on the stage of the disease, with low-grade intracompartmental lesions offering the best prognosis after complete surgical resection with surgically clear margins. Lesions with isolated pulmonary metastasis can still be surgically resected if metastacectomy of the isolated pulmonary lesion is feasible. Usually, appendicular skeletal involvement is amenable to wide excision, hence the lesions tend to fare better with surgery than with those occurring in the axial skeleton. Lastly, about Ewing sarcoma. As I mentioned, it's a very highly malignant tumor that is derived from bone marrow and is the second most common tumor of the childhood. This tumor usually involves children from 4 to 15 years and rarely develops beyond 30 years. The affected bones usually are the femur, around 50 to 60%, tibia 25%, humerus 11%, and flat bones around 10%. 40% can involve in the pelvis, 14% the scapula. As far as location within the long bones, the tumor is almost always metaphyseal or diaphyseal. It is the most lethal bone tumor, and it's usually associated with peripheral neuroectodermal tumors. This is how its distribution is done. Usually clinically they appear as painful, and at times they usually mimic osteomyelitis. And the differential diagnosis will be osteogenic, eosinophilic granuloma, infection, osteosarcoma, and leukemia. This is how they clinically appear. A large lesion in the distal femur, the typical appearance on the X-rays. They have onion skinning, as I will show you afterwards. This is a drawing of the proximal femur, shows intramedullary involvement of the tumor extending to the soft tissue through focal cortical destruction, and also the drawing reveals permeating through the Haversian canal and neurovascular channels. This pattern of extension allows continuity between medullary and soft tissue components without large areas of focal destruction. So there is, and histologically, you will see sheets of monotonous, small, round blue cells and with prominent nuclei. Many of them have pseudo-rosettes. This is what I'm talking about, the onion skin appearance. They are usually typically seen in Ewings, and reactive sclerosis, irregular periosteal reaction, along with the soft tissue mass. These tumors tend to be largely poorly marginated tumors, with over 80% demonstrating extension into adjacent tissue. By the time the patients come to us, they have a large soft tissue mass. The appearance of a permeative lesion on the tip of the tibial diaphysis, better appreciated on the axial view. Again, lytic margins, plain radiographs showing a large mass with destruction of the proximal humerus, and axial CT scan of the left shows a dense sclerotic involvement. So I'll be a little more quick so that I involve my panel. This is how you'll see in the MR, showing multiple metastases in the whole of the skeleton. Malignant chemotherapy with alternating courses of two regimens, usually vincristine, doxorubicin, cyclophosphamide, ifosfamide, and etosemide. Then we get neutrophil support, red blood cell, and platelet support, and surgery. So the mainstay of treatment is surgery and radiotherapy. Follow-up, usually primary and metastatic sites evaluated approximately every 10 to 12 weeks during therapy and every 3 to 4 months following the first year of therapy. After 5 years of disease-free remission, no further scanning is indicated. However, the patient should have an annual follow-up visits to monitor the function of the primary site and late effects of therapy, preferably in a late clinical setting.
And you can find all of our lectures uploaded on the Ziauddin Orthopedics webinar channel on the YouTube. Thank you so much.